Space.
Me do my Don Lemon.
Oh, that's good. Good evening, as Sean's doing his Don Lemon. Thanks for joining us tonight. Sean, I know it takes a bit to kick in. Are we?
We're good.
Good. All right. There's a lot going on, so thank you for joining us. I first will, I guess, introduce my cohorts here with me tonight. Shauna, I guess at this side, that
side. Good evening, everyone. My name is Shauna Whittingham. Welcome to Talk Forum. We can't wait to get into this discussion with you guys.
Hey guys, I'm Sean Spalding, and yeah, likewise, I'm looking forward to getting into this. And I must say, Kim, you, I know you'll get into this, and you are the one that had brought this topic to the fore. But it was a very interesting deep dive. So it was. Thank you for bringing this topic up so we can address it.
Yeah. So we were kind of talking before the show. So I was telling Sean and Shauna, but for you guys tonight, you know, we've talked about so many topics on this forum around government and education, criminal justice reform, just, you know, the political landscape and environment that we're in right now. But we haven't really tackled, you know, or talked about the disparities in healthcare. And so when we think about the external world and all of these factors, you know, I was thinking, you know, it really, when we look at our own health and well-being, it's so important that we're at our best when we're stepping out into the world. And so, you know, easier for me to step out into the world. We talked about my, you know, I wave my white privilege flag from time to time. I recognize it. So when I think about the challenges that people of color have going out into the world every day, you know, I think about those with chronic illness, you know, going through extreme medical events in their lives. And when you're not feeling your best and, you know, you're feeling unwell, and then you're also dealing with all of these issues on top of it, it just compounds everything and it makes life that much more difficult. And so I was, you know, just doing some research and looking at, you know, the current environment we're in right now. And I know, Sean, you know, you'll talk a little bit about how we got here. But when we look at the current, you know, climate we're in right now, there is huge gaps between white American people and, you know, people of color American people, right? Whether you're Black, Hispanic, Asian, American, the access to healthcare, the quality of care that you're receiving, and your clinical outcomes are so much worse. And so we'll talk about chronic conditions, why we think that is. Specifically, you know, with females, Shauna, you know, I'd like to talk about the pregnancy experience, which should be the greatest time of your life, the most exciting time. For many African-American women, it's become a dangerous time for them. So we'll talk about all of these experiences. But first, I wanted to maybe, Sean, you know, you mentioned there's sort of race-based medicine and how we got there. And I was thinking maybe we could start there, because myself, when you mentioned that, I thought, I didn't even know there was such a thing as race-based medicine.
Yeah, and the thing is, there's a long arc, but it has not ended, and there's no end in it. We're still experiencing right now that race-based medicine and the disgusting beginnings of that kind of approach to medicine, and also the devaluing of the Black body. You know, we can look back and think at instances that we're all familiar with or we've heard, like the Tuskegee experiment. And then there's also the Henrietta Lacks, whose cells, her cancer cells, were taken without her consent and used for research when she should have been receiving treatment. The Jim Crow segregation of medical services, the mass sterilization of Black, Mexican, Native American people up until like 60s and 70s, and even more recently in the California prison system. So you have the many instances throughout history where medicine has either been not appropriated for Black people or they have been used as the vehicles to improve the healthcare of other people's. Right. So, in other words, for lack of a better word, say guinea pigs. Right. And there's a long history of that. And we can get into how those instances play in right now, even some things that are questions that we answer when we go to the doctor. I would hope that at the end of this conversation that we start to question why we're being asked certain questions when we go to the doctor's office. Why am I feeling outraged? Right? Why is that a factor in your administering medication or administering pain relief or anything? Right? And why is that playing a factor? And I must admit that there are certain things that I myself took for granted and said that, oh, well, that afflicts Black people. That's something that happens to Black people, right? But there's also the converse, where there are things that the medical community more often than the layman has said that, oh, these things only happen among white people. It doesn't happen to Black people, like cystic fibrosis. There have been many misdiagnoses for Black people where they've been treating an ailment and not realizing that this person actually has cystic fibrosis, just because they were against the thinking that a Black person could have this disease. So it does cut both ways, and it cuts both ways, and affects everyone, right? So these disparities are they're among the doctors. They're also on the technical side, because we'll get into also the algorithms, because just like insurance companies, they're actuaries that make judgments as to what kind of healthcare should be administered based on the data that they're provided. And race is injected into that data when that's very muddy waters. But we can get into that. But yeah, a long arc of history.
It's interesting because, I obviously have heard and read and know the stories of the testings of, medications and topical things with skin in the jail systems and all of that. And I don't know that I've ever connected that we've carried that forward and not really changed the mindset of these medical professionals that are continuing to sort of move this stuff forward. And they've really brought some of these inherent biases with them. And so that's interesting because, you read stories and you hear things, and I don't know that I ever connected that has led to present day disparities. And so that's all right. Thank you for bringing that even to my mind.
Yeah. At the end of the day, it boils down to economics. At the end of the day, if you research a history about how we practice medicine, Western medicine in the United States, the Carnegies, the Rockefellers, they went into the med schools and basically had their list of medicines. And depending on what the ailment is, you ask the patients these sets of questions. And depending on how they answer, you administer 1, 2, 3, 4 of these drugs. It all boils down to the drugs. But I could share I could share more, but I'll share 2 personal experiences. One was me and one my late husband, as far as race-based medicine, you mentioned, Sean. So go into the doctor for my regular annual. I work out 4 or 5 times a week. I still do. All right, so I had a propensity to drink a Pepsi now and again, and I like my chocolate. But one of the questions they ask you is, of course, they ask you race. And then in the Black community, they ask if anybody has ever had diabetes. So my grandmother passed away from a diabetic coma. My mother had it. And here I was. This is many years ago, pre-children. And so I hadn't heard back from the doctor in about a week. So I called for my results. And in a panic, the nurse says to me, you need to come in. You need to immediately start. We need to put you on insulin. I never forget. We were working together. I won't say where, Kimmy. And I couldn't get there until after work. I remember them opening the door in the back for me to come in, and the nurse telling me, you have to go and fill this prescription. You need to inject yourself. And I'm sitting there just shocked. I've never injected myself with anything. What are you talking about? And they had me in such, we were raised to whatever the doctor says is what you do kind of thing. I never forget, I went to Publix to fill the prescription. And as the pharmacist was pushing it across the counter to me, I pushed it back and I said, I don't need this. I remember him looking at me like, are you crazy? And at the time I went to the medical director and I said, there's something odd about this. I have none of the symptoms they're asking me or suggesting that I have, and something just doesn't feel right. I mean, when she first told me the results, I laughed. I said, you're looking at somebody else's file. That's not me. So long story short, I started tracking my blood sugar, started documenting what I was eating. So I went to see an endocrinologist, and when I went in, he said, why are you here, for thyroid? I said no, for blood sugar, and he was like, So he's looking at the file, he goes, what did they say your blood sugar was the day they decided you need to go on insulin? I'm like, I don't know, it should be in the file. Turns out they did not even check my blood sugar that day.
Oh my God.
So, look, I mean, an insulin, if you start taking it, it's not a medicine you can stop taking. Okay, so that's just one example. My late husband, they changed his medicine. I won't say the name of the medicine at risk of being sued by the pharmaceutical company here, but there's a particular medicine they give people with high blood pressure. If you're a person of color, it shuts down your kidneys, and you now you need to take a water pill because you start retaining water. And within a week, he was dead.
Wow. Yeah, there you go. Yeah. And that's prevalent across so many disciplines in medicine. You have the Society of Thoracic Surgeons that going into cardiac surgery, I'm gonna keep going back to this because they act like actuaries and when they make these decisions. But there's an algorithm that attributes the risk of death by nearly 20% increase if they're African Americans that are going into a surgery that and this would be a normal surgery that would be administered for anything regarding cardiac issues. So if you're using that algorithm, it's going to steer minority patients into deeper issues because you're steering them away from surgery. So you're now compounding the issues where they could have been resolved earlier, right? I think Shauna, you had brought up before we went on about the disparities in dealing with kidney issues, right? And again, we see issues with treating Black people who have kidney issues. There is, I forget what it is, what the index that's used, but the notion is that Blacks have more muscle mass, and because Blacks have more muscle mass, the algorithm they use, I think it's the kidney donor risk index. Kidney index that's used to determine how to treat, and it adjusts the algorithm by about 13 to 14% because it's factored in that Blacks have more muscle mass, so they're be able to have better kidney function. So where you would be going now seeking transplantation or other treatments, they're not administered to Black people. So there again, you have issues with heart issues. Then you have kidney issues where race is playing a factor where it should not. And if we're not careful, we'll look at certain things and we'll say things in passing, like if you picture the face of diabetes, I don't know about you, but a lot of times I picture a Black person who has diabetes. But without getting into why there's nothing attributing Black people as to having a higher propensity for diabetes, but there is with the diet. So there's nothing to do with the fact that they're Black. It has everything to do with the fact that genes has to do with your what you inherit from your parents. Also has to do with your eating habits and your diet, and that's what it is. It's nothing to do with your race. And it almost sounds strange to say that it's nothing to do with your race, because that almost, when I say that, I'm attributing some medical medical attribution to race when there is none, because
Right.
it's a political and social construct. There's no backing behind race. So
no, we try to find logic in things, and then you have to remind yourself, no, your kidney is biologically the same exact kidney as someone who has white skin. Like a kidney is a kidney. But I mean, you're touching on something where there are socioeconomic aspects to this, right? So we know that whether, in the lower economic, entials of, the country, or, whether it's poverty, lower class, middle class, even working class, upper class, right? There are factors that play into your eating habits, right? That put you at risk. And so if you're a single family, a single parent working, not home, not able to make that healthy dinner, maybe can't, you're eating the kids are eating fast food a couple times a week, every night, maybe, then you start looking at even like, the food stamps and the WIC for pregnant women, when you're getting assistance to buy good food and you're supposed to be getting healthy food. And what's approved for WIC? The white bread, not the whole grain, what I mean? So even the products,
everything else.
So when we think about diet, it's not everyone can afford to, go buy organic and eat a healthy 3-course dinner every night after work. And so it's, it's like one other layer of challenge. So not only now am I kind of at a disadvantage, but now my diet is now going to impact, my health. And then, by the way, when I go to access care for these health issues, I'm more than likely seeing a white provider, because, we talked about this before, but, African Americans make up 13% of the US population, but only 4% of doctors. So you're more than likely going to see a doctor who is not, of your same race or culturally connected to you. And so they are more likely to bring in those inherent biases and make assumptions and prescribe the wrong medication. There's a study when we talk about just prenatal and all of the issues going on right now with females and pregnancy things. But there are studies that are showing providers think Black women are tougher and stronger and can endure a little bit more pain than a white woman. So when they're expressing something's hurting, something's ailing, there's an issue, they're being ignored.
Right.
And so
before we go down that road, because I definitely want to talk to that, even based on my own personal experience. But, you mentioned the percentage of Blacks in America, and then you mentioned the percentage of doctors. What's interesting, and some may even argue, is that the majority of nurses in the United States are actually women of color or people of color. However, what's happening is, have you guys ever heard of a hackathon? Do you know what that is?
I've heard of a hackathon, but there's several different kinds of hackathons.
So a nurse hackathon took place for the first time in 200 plus years of medicine in the United States, just in 2016. So I don't know if you do this, but whenever I go to the doctor, I befriend the nurse, because he or she is usually the person who sees firsthand, and no disrespect to doctors, but so many have this godlike attitude. Some of them don't talk to you. Some are great and have excellent bedside manners. But my strategy is to befriend the nurse, to get them to, they're not supposed to do this. They're not supposed to, it's a big hierarchical thing in this healthcare. It's so ridiculous. But the nurse, to me, is the front line. That person is the one who's going to see and know immediately. I don't know if you've ever gone to the doctor, experienced something, and I pick up on energy, and I can tell, and I went through it with my second pregnancy, that the nurse saw something, and she wouldn't say anything to me until she had to go and tell the doctor. But before we even get into that, but the point is, again, it comes back to economics. To me, you guys hear me say it all the time, when this shit don't make sense, follow the money. So the majority of nurses we have 19 million nurses in the world. We have 4 million in the United States of America. And the majority, I don't know what percentage of that, but are people of color. But they have not been involved in either, and this happened with the stethoscope, in the products and the type of care that's coming to the market. The doctors and other people, typically white men, make these decisions. They don't involve the nurses.
Yeah, one would think that they would have the most knowledge to share, to be able to deal with the various nuance and illness that comes into the hospital or the doctor.
That's the point, exactly.
Yeah, good thing. Yeah, but applying again, going back to the applying race to the administration of medicine or treatment, it's an animal that eats itself. So, and the reason I say that is because if you look at the opioid epidemic that we're dealing with right now, so the opioid epidemic has a white face, right? We know that. The crack epidemic that was happening years ago, not to say that crack is non-existent, no, but at the height, it had a black face, right? And it was demonized. And it was, we're looking at these people as though they're the scourge of society, and it's their fault. And they are
criminalized it.
Yeah, and they're a stain on what we know as ourselves as Americans, right? No, with the opioid epidemic, it's looking at victims of the drug, which is a wholly different way of looking at drug abuse, right? Yeah. That kind of empathy was not given to Black people during the crack epidemic. But here's why I say it's an animal that's eating itself. It's because why, with so many white people, mostly white women, the victims of opioid addiction? Reason for that, and I'm not saying it's the only reason, but a good portion of the reason for that is because when we go into the doctor's office, or we're coming out of treatment, there is a much less likelihood of pain relief and pain medication being given to Black people than there is to white people, right? Because the notion is that Blacks have a higher threshold for pain. And I would imagine there's also an empathy, because you feel sorry for them, you don't want to see them suffer, and that empathy is bestowed upon white people more often than is bestowed upon Black people. And that has a lot to do with what you were saying, Kimmy, because if you have more white doctors, they can empathize more, you would think, with people that look like them. So now, if you're giving this pain relief, this pain medication to this subset of people, who is going to fall victim to that addiction? It's going to be that same group of people. So now you have the opioid epidemic hitting people that were being prescribed this pain relief over Black people. So while I'm thankful that like me are not a majority of that epidemic, it gives me pause to think why we are not, right? It's a problem. It's a problem. And that really illustrates the fact that this is an issue that affects everyone.
Yeah. No, it's interesting because that's another avenue I hadn't even considered when thinking about all of this, is how the opioid, we know how things are marketed in the media, and they're, the crack and epidemic versus this and all of that. But to think about why, right? And I even said it, doctors are not as empathetic, and they assume that the Black woman or Black man can take more, tolerate more. But you're right. At the same time, well, wow, look what that did to the white population, that they were over prescribing. Yeah. It hurts everybody. It hurts everybody. When you bring race into medicine.
You have like children that come into the doctor's office, and if they have pain in their stomach from like appendicitis or something like that, they are far less likely to receive any kind of relief or any kind of medication to relieve that pain than a white child going into the doctor's office.
Yeah.
And I would also add that is, of course, more often than not, they're seeing a white doctor. But here's the other flip to that. It's likely too that even if it was split across black and white, that maybe that they would still receive more pain medication, because that kind of racial tendency, racist tendency, or racist approach to medicine is not exclusive to white people. It's not exclusive to white people. So
I want to venture over to the cost of healthcare, and then maybe even healthcare reform and what's happening in politics and the government right now. But let's even just look at the cost of healthcare in the United States of America. I think for us being a first world country, and for how hard we work, for those of us who work hard, I believe the system has failed us as far as the cost of healthcare. Let's just pretend, let's say, I think the average annual income is lower than this in Florida, and specifically South Florida. But let's just say household income, $50,000. Even then, have you seen these plan designs? We, two of us on this call, we work in the industry. You're talking about the government decides that a $1,400 deductible is anything less than that is not considered a high deductible health plan. It's for $1,400 and up is what's considered a high deductible health plan. So what that means, without getting into the nitty gritty, is you need to satisfy, you need to pay, and this is for one person, not family. You need to pay out of your pocket $1,400 before any of these insurance carriers start to pay a portion of the bill. You still have your out-of-pocket maximum that you need to get to. So you take an average household income of $50,000. Guess what? People are not, luckily, wellness, colonoscopies, pap smears, mammograms, luckily those are covered 100% because of healthcare reform, a big part to do with it. So guess what? Somebody has a stomach ache, or somebody has an issue, and they know that they're gonna have to pay, just as a simple example, $1,400 when they have their mortgage and their rent and food and So people aren't going, the system has completely failed us.
That's a loaded one, Shauna, because I feel, the front line is a plan design, your insurance plan, which is what you're speaking to. But there's so much that goes on behind that. So it's do you need, so the high deductible health plan and what qualifies a high deductible health plan, that's tied to a tax deductible tax benefit account, which is really, in my opinion, with the creation of health savings accounts and the ability to put money aside pre-tax to spend on qualified health expenses, that's what drove and started this high deductible health plan concept. And if you think about that, by nature, that is designed for the wealthiest portion of the population, right? If I have thousands of dollars to put aside each year pre-tax, set it in an account, that's great. That works for someone who has that kind of money. And it's nothing for them to go to the doctor and pay $150, $200, $80 until they hit that deductible. They're essentially self-insured. So that concept was great for those people. Guess who rolled that concept out? The Republicans, looking for another tax, right? That doesn't help the folks who can't afford to put more money from their paycheck aside to save. Yeah, it'd be nice in theory if everybody saved for their healthcare expenses. Not practical. And then you're right, people start deferring care because they don't have $80 to go see a doctor. So what happened was you had major corporations and people really starting to embrace this high deductible healthcare, concept. And so we've moved in that direction. And you're right, that does not work for most people. But at the same time, there's so much more around cost of healthcare. So there's, we can talk about health insurance premiums and your plan design, but that doesn't really address the cost of care. The cost of care is how much your prescription, what are the pharmaceutical companies charging for these prescriptions? What are the hospital and delivery systems charging for you to go get that mammogram, that colonoscopy, that ultrasound for your pregnancies? Right? What are the labs charging for all this blood work? What are your doctors charging? So costs continue to go up and up and up in these areas. But I 100% agree. What's not going up and up and up is the quality of our clinical outcomes in this country. And the rest of the world is surpassing us. When we talk about mortality rates for women dying for pregnancy-related issues, we are worst in the world for the industrialized countries. We are worst in the world for women dying during childbirth or childbirth-related causes. In the United States of America, where we spend the most in the entire world on healthcare. Yeah. So it's really unacceptable. I think it's a much bigger issue than just my health insurance plan design. There's so many things that go into it. And I think, it's a good segue into the Affordable Care Act, because the Affordable Care Act was really that stepping stone, that first piece to say, we need to drive down costs. This is not sustainable. We need everyone to be able to get health insurance. We need them to be able to afford health insurance, and we need them to have quality care. And so they tried to address all of that. It was a great starting point. And unfortunately, it continues to be chipped away at. And now in November, we potentially have, arguments at the Supreme Court to repeal it altogether.
Do you know what the numbers are for, you mentioned pregnancy, mortality, pregnancy. Do you know what the numbers are across the various races?
Go ahead and tell us, Sean.
No, I don't know. I'm really just asking. I don't know.
Yeah. So I know that Black women, because this is specifically what I was researching for tonight, Black women are 3 to 4 times more likely to die from pregnancy-related issues. So I don't know the number, but they are 3 to 4 times more likely. So they are predominantly driving, our numbers. If we're worst in the industrialized countries, it's because of that factor. And it's unfortunate, because these are all preventable things that should not happen.
The reason I ask is because the pregnancy is a touchy one on a personal level, but for me, and also because of the cesarean question. And as a man, I was always under the assumption that, okay, so if a woman had a cesarean once, the danger in her having vaginal birth after is extremely high. So you don't do vaginal birth after cesarean. But that is based on an algorithm, and I keep bringing up algorithms because that's what I do in my day job. I work with algorithms. This is just a different one. But the algorithm that VBAC uses, vaginal birth after cesarean, predicts that the danger posed for Black women for vaginal birth after cesarean is higher for Black women than it is for white women. And that is factored into the algorithm when they're making that decision. Keep in mind, I'm not talking from a historic reference. This is what's happening right now. Yeah. This is what's happening right now. And when I say this on a personal level, it was also brought home when my daughter was giving birth. It's going almost 2 years now, my grandson. And when she's giving birth, they came to that conclusion really fast. No, this is her first child, but they came to that conclusion very fast that she needed to have a cesarean. And, I was hesitant, as to say, well, she's fine with me, because you're the dad, so you got to time in and whatnot. So it struck me as odd. And it was after that I discovered that, I knew there was disparities, right? And I knew there was the hospital gets more money for doing cesarean. So I knew there was financial motivation also. But financial motivation aside, there is a racial component that should not exist there, because there is no heightened risk to Black women simply because they're Black. It's just it makes no sense. Again, it's muddy waters. They're using race as a factor in that algorithm when it should be something more concrete. Maybe you should look at the health of the mother instead of just looking at the race, right? But that is a much more expedient way to go about it, by looking at visual race.
And you talk about algorithms, but we are moving towards a database driven society, and specifically in healthcare, everything is moving towards this data driven decisions. You have, and I'm in the healthcare industry, but you have these 4, 5, 6 top insurance companies specifically. They're able to see the claims data, right, on the entire U.S. population. I mean, they've got the data. You've got one of the largest companies owns, and predominantly, if you look at their stock price, it's not because they're killing it on their insurance sales. It's because they're so diversified, and one of their biggest holdings is data, and so they're able to consolidate all of this data, put it through the computers. And that's what's driving some of these decisions. And when these race-based decisions, if they are coming to these algorithms, and we're losing a little bit of that humanity, right? So the doctor actually sitting down and saying, well, talk to me, let me understand what's happening with you and your body right now in this moment. Not what the data is telling me should be happening because you're a female and you happen to be Black.
So data is the new currency.
Exactly. That's it.
Data is the new currency. But what's that, Sean?
Just run amok. No, it's just run amok. When I say run amok, I mean it's just not. It's not using clean data. In this instance that we're talking about, it's not clean data. And a lot of these instances that they use to build the algorithm, they can't replicate it, right? So if they changed up the studies, you'd be hard pressed to try and replicate the foundations for some of these algorithms. But I said, it's about money.
You need to see a picture of Sean's grandson. He's the most adorable.
Yeah.
I saw a new picture this week. He is too cute. But before we go back over to the Healthcare Act, I know you had done some research, Kimmy. We were talking about pregnancy and Serena Williams. Did you want to go ahead and share that?
Yeah, I mean, we talked about, we talked about women are 3 to 4, or Black women are 3 to 4 times more likely to die from pregnancy-related conditions or issues. And so I was trying to kind of go backwards into why is that the case, right? There are programs available. The government, isn't perfect, but there's WIC, there's Healthy Kids. There are, social programs around trying to help women eat healthy while pregnant, trying to prevent premature births, right? Like, so all of these things exist, but what you can't really solve for is just the psyche or the inherent biases and racism that happens when you walk into a doctor's office and you're more than likely going to see a white provider. And so both Beyonce and Serena Williams spoke out about this with their own pregnancy issues. And we're talking about 2 of the most famous women in the world. Beyonce's experience wasn't as severe as Serena's, but Serena Williams has a pre-existing condition. She talks about this publicly. Something with a blood clot, takes a medication. After she delivers the baby, she's feeling shortness of breath, still in the hospital. This is a world-class athlete. She is in good shape. If I say I'm feeling shortness of breath, I could see where someone would say, well, Kimmy, you haven't ran in a while. But this is Serena Williams, all right? And she's ignored in the hospital. One of the most famous women in the world, ignored. And, fast forward a day and a half, or I don't know, I didn't have the exact timeline, but still in the hospital, she has a blood clot go to her lungs, and serious complications because she was ignored. And I don't know if some of that goes into, like, again, I'm waving my flag here. I can make a scene in a hospital when I'm being ignored. And you can imagine this woman, right, who just had her baby is famous, but take the famous part away. She's probably feeling like, well, if I make a scene, if I yell at these nurses, if I say, hey, listen to me, you're ignoring me, I'm now a bitch.
She's an angry black woman. She's an angry black woman.
Right? When she yelled at the judge, she was crazy. And so she's now not advocating for herself out of fear of judgment and what people are going to say, and she could have died.
Yeah.
And so that was just, that stuck with me because we're talking about an extremely wealthy woman, famous, access to the best doctors in the world, is fit and healthy, and she still had an issue when delivering with her first child. It's really unacceptable. And with the amount of oversight that happens at these hospitals, with the amount of women of color on the nursing staff, we have to do better. Yeah. We have to do better.
Yeah, I know just for myself personally, like I'm particular about my doctors, because first of all, when you're already not feeling well and then to be mistreated or ignored, I had an actual flip side of that experience with my first child. So I wanted the epidural, but it got there too late. So I just didn't have it and went through the pain of having my first baby.
Oh, you did?
Nope. No, the second one I did, to the point where they had to tell me when to push because I wasn't feeling anything. But the first one, I kept saying, I don't think she can fit through there. But so what was interesting though, and again, it goes back to the money. After I had the baby, I'm now in a room, out of the delivery room into a hospital room. And I was offered narcotics 5 times. So to the point where I had to say to the nurses, I thought I went through the hard part already. Is something supposed to happen? Am I supposed to experience some kind of pain after that? Because they get paid big bucks just for 2 Tylenol. Let alone narcotics. But, I have this preconceived notion. I just always hear my mother's voice saying, hey, if you have to go through any kind of surgery or anything, try not to ever take the painkiller because painkillers are addictive. So, but it was interesting. 5 times in the span of 2 days, nurses just came through and they kept offering narcotics.
Yeah.
It's so depends on where, depending on which hospital you're at. Care varies. It's so inconsistent. Experiences are so inconsistent, and that's what leads to these issues that we're seeing.
We've spoken before, Kim, about the value in seeing a physician that looks like you, right?
Yeah.
Is there any value in it? Do we feel like minority communities are less served by physicians that don't look like them? My feeling is no. I think some of the numbers scrub out to show that the answer is no. When I say no, I mean that they're not being given the best care that they could receive. I don't know what your feeling is on that, or if you guys work within that field, if you've seen any data or gotten any feedback along those measures.
So so 2 things. When I look up to go find a doctor, I'm a Jewish girl. I look for a Jewish doctor. I don't know why. I've said this before.
Because you want to live.
I don't know if it's I want to support my people.
You want somebody to hear you when you speak.
Yeah.
Or I think well, genetically I do have. So as an Ashkenazi Jewish person, there are genetic things about my body that put me at different risks for different diseases and things like that. So I do try to find, a Jewish doctor who specifically, caters to BRCA positive, which I am. But even before that, I don't know what I honestly, I dig inside myself all the time, and I don't know why I've done that my whole life. But now that I am busy and I don't have a whole lot of time, I can't stand my kid's pediatrician. If my little one gets, any little thing, I'm like, I'm not dealing with them. But there's a minute clinic, a walk-in clinic at the Walgreens. actually runs it. And there's a Black Jamaican woman who's always there during the day. And she's become like my go-to. She's phenomenal. And I don't know, had I not gone into that walk-in clinic, I don't know that I would have ever thought to like choose her.
Yeah.
And she's phenomenal. And she's great with Aiden. She checks him out, pink eye, ear infection, whatever it is. And she's great. And we connect and we vibe. She doesn't overprescribe. And, it's like until you actually experience it and you're like, yeah, why was I doing that all these years? I don't know. But on the flip side, I'm different, right? Because I'm not at risk of being mistreated, right?
Yeah, you're for lack of a better word, the default.
Correct.
Yeah.
I don't have the risk of, if you two go to a provider who maybe is assuming things about you because you're Black, or assuming you don't need certain tests, or you do need extra testing, like I don't have that risk. So I don't know how I would feel, but I would imagine that I would be more likely to access care. I would be more likely to go in and see my doctor. Early detection is key. And I think I'd be more likely to go in and treat things. Aiden is moving in the background.
Okay.
If my doctor was like me, right?
Yeah.
I felt connected to my doctor.
Yeah.
Yeah.
It makes perfect sense. And, I know when we're talking about medicine, we tend to talk about the physical, right? The physical. So dealing with any issues with the body, the organs, any issues like that. But it also comes across in dealing with psychological issues and mental issues also, because there's a running theme in the Black community that Black people don't like to get therapy, and studies have shown that that's not true. Black people don't like to get therapy from people who don't look like them or relate to them. Because
how is a suburban middle class white woman going to understand the trials and tribulation of a Black man making minimum wage living in the projects? How?
Yeah, she can't feel that pain. She can't feel that issues that could arise from that. And that's not being racist in its approach. It's just that you have to be able to relate. So, the show is about not factoring race in the administration of medicine or prescription or what have you. But there is another side to it where race can play a part. And this is an instance where race can play a part, because you have to be able to relate to your patients at some point, even going back to even the body. If we're talking about diet, right? Because diet bleeds over into our health and our general health. If as a man with a very peculiar appetite, because West Indian, I eat differently. I don't eat like the typical Black man from America. My meals tend to be different. I love a lot of pepper, right? Things like that. Right, for the doctor to come to me and tell me, well, you're gonna have to cancel that, but it's no big deal, Sean. No, what do you mean it's no big deal? Why don't you give me some? I need you to give me some options, bro. I need you to give me some options.
Jumping late
that you're actually going to be able to implement.
Yeah.
Right. So for the success of the outcome, right? Again, it's that relatability, right? But jumping lanes back over to the Affordable Healthcare Act is interesting, because as having a conversation just this week, and I love to banter with this person, especially because we don't ever see eye to eye. We were talking about the affectionately called Obamacare, and his position is he didn't agree with how it was implemented. And you guys know we try not to talk about number 45, but you know that he is trying to strip and undo everything that's done. But I think the both of you and everybody with any kind of common sense will agree that a shift in healthcare, something as big as this, takes time. So, and everybody knows the struggles that Obama went through with getting anything implemented. So, okay, and then he got through with the Affordable Care Act. The second piece of it, then, I mean, ultimately, that whole concept, just for those who don't know, is to make sure that there is affordable healthcare for everyone. Because typically, and you know this, Kimmy, is you have a 20-year-old male on the benefits. He would rather not have $20 come out of his paycheck every week to pay for something that he doesn't anticipate, because you're young, you're healthy, you feel invincible. You're not thinking about healthcare. You'd rather use that money to go buy beer. So the Affordable Health Care Act was to basically insist that everyone, young, old, healthy, sick, has benefits. Basically, there would be some kind of repercussion for not having the benefits, where you're taxed or you're fined or blah, 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 right? What needed to happen after that was that wellness component of the Healthcare Act, or the Affordable Healthcare, where for those who are healthy, get them educated in ways that Sean just shared with us. Okay, you want me to change something about my diet, but give me something that is doable, that where we'll have a successful outcome. And then the other option was to whoever is sick, get them healthy, not hooked on drugs, but actually cured. Okay, because that's a whole separate conversation. There's the pharmaceutical side of it, which is it is legalized drug trafficking as far as I'm concerned, because I think America is one of the few countries where you can legally advertise drugs on television. But anyway, so affordable healthcare, again, insists that the young people pay into the benefit, keep them healthy, and ultimately what that would do is shrink not just the cost, but the pool. It's insurance, it's a pool. You know, yeah. everybody, so you're not just having adverse selection, but it's being unraveled as we speak.
Yeah, I think so. With the Affordable Care Act, for me, you know, and I've been in the insurance world for I think 18 years now. I am a fan. I was a fan when it was being rolled out. It was a battle. They got the votes in those first 2 years of Obama's first term, and they passed this in 2010. And here we are in 2020, 10 years later. And I personally still don't quite understand what everyone's issue is with this. I tend to think this is a dig and a racial issue in itself. I think it's a dig at Obama because, you know, it's coined Obamacare. But what this Affordable Care Act did is really incredible if you think about it. And it's not that different than the Medicare system that exists today. So in today's society, I don't have a choice. You are taking taxes out of my check for Medicare. I pay into Medicare. Everybody pays into Medicare. We don't have a choice. And at 65, you automatically get that one part. You got to pay a little bit based on your income for the other part. I mean, this is what's been in this country for decades. It's Medicare, right? But it doesn't start until you're 65. So when I break down the Affordable Care Act, I think it did an incredible job of saying every American needs to have insurance. And by the way, it did more than that. I'm going to come back to it. By the way, in the last 10 years, so many countries, I'm actually in the global field in what I do personally. So many countries have followed suit and are implementing what we call here an individual mandate. So many countries are mandating, requiring that everybody have health insurance. You have to show proof of health insurance to even travel in, to get a visa, to even visit their country, let alone work there, let alone live there. So what we are battling to repeal, other countries are adopting. Okay. Yes. So what we're saying is everyone gets in. You're going to get 100% preventive care, right? Early detection is key. We know this. Why are these clinical outcomes? And when people say Obama didn't do enough for the African-American community, it kills me. Because when we look at these statistics that we mentioned, Right? Women are dying at a higher rate. Black men, 24% more likely to die of cancers than a white man. Early detection is key. For whatever reason, right, that these tests weren't getting done, these preventive screenings, what the Affordable Care Act does, it says everyone can get it at 100%. There is no cost to you to get a mammogram, to get a pap smear, to get a colonoscopy for preventive reasons, right? Preventive care is covered at 100%. Everybody can get this plan, right? You can't be denied for pre-existing conditions. And if you get approved, they won't exclude your pre-existing conditions from being covered. So no matter your health status today, get on the plan, get covered, right? Then it went a step further and said, we know that there are financial issues. Not everyone can afford this. So they said, let's look at it as a percentage of your income. So as a percentage of your income, if you were at the federal poverty level, you shouldn't have to pay anything towards your health insurance premiums. We're going to go ahead and subsidize that. And then as you make more money, you pay percentage of your income towards that premium, and subsidies cover the rest. Then it goes a step further. It says, wait a second, we're helping you with your premium, but your plan design has $1,000 deductible. Do we really think someone who can't afford or is living paycheck to paycheck can meet $1,000 deductible? No. So it has cost share reductions baked in. Depending on where you fall on the federal poverty level or relative to, we're going to buy down that deductible for you. So this plan really, this Affordable Care Act really hit on all cylinders to say, we're going to make this accessible to everybody to be able to get into this system. And we do it with Medicare. Why not do it for everybody, right? Because we know everybody benefits when they have access to these insurance plans that help them then get to providers where they can get quality care.
Well,
so
go ahead.
No, I know we're getting at time, but so this has been fought multiple times at the Supreme Court. They've tried to repeal things. This current administration has essentially said there will not be a penalty for not having. So it essentially nullifies the individual mandate. And so now the case that's going to be argued before the Supreme Court is, well, if there's no individual mandate, then the entire thing, the entire Affordable Care Act, that entire piece of legislation is essentially nullified. And that's the arguments that they're going to put forth in November. And we will potentially have a 6-3 majority, conservative majority Supreme Court. The reason this has gotten to the Supreme Court is because all throughout the country, the lower level circuit courts at the federal circuit courts in different states throughout the country where Trump has, and I said his name and I don't like to, but I will on this topic. He has put in place so many federal judges throughout the country who do not deserve lifetime appointments to these positions, but they're now in place. So as these lawsuits come up, these judges are ruling in favor and allowing it to get back up to the Supreme Court. So that's what we're going to see in November. This administration does not have a plan. If they repeal the Affordable Care Act, we essentially, who knows what happens? But all of these statistics that we talked about tonight, all of these issues where the Affordable Care Act tried to kind of bring us forward in these areas around access and affordability, they are blatantly trying to undo without a backup plan. And so that's kind of where we can kind of start to wrap up here. But I know we have a guest who wants to join October 8th.
Yeah, so in 2 weeks, there are opposing views on the show we did 2 weeks ago on reparations. We also plan to have some discussion, continue this healthcare discussion, just a different point of view, which we welcome. And I just want to take the opportunity that whether you're watching this now or even later, we encourage you to leave us comments about your views, your feedback, because even if we don't answer them during the show, Sean will go through them afterwards, right? And Kimmy, and respond to them.
And maybe invite them on as a guest.
Exactly. So we definitely want to hear from you. So make sure you follow us on Facebook, Instagram, and Twitter.
Yeah.
Yeah, I just wanted to make one before we close that, seeing as though this was on race and medicine, I just wanted, it's a charge not to just the medical community but to all people, is that when we see differences in health outcomes, let's not look at the racial lines, but more look along the lines of inequity and what's available to each and every one in this country, because a lot of these topics are as it pertains to America. And you mentioned, Kimmy, about you don't know if it's a dig on Obama with the whole trying to fight against the ACA, or if there's a racial component. To be honest, I think there is a perverted meritocracy that's involved there. When I say perverted meritocracy, is that anyone who needs the notion is anyone who needs free medical care is because they didn't work hard enough to be able to afford medical care. So why should we award them? And that's the kind of thinking that we need to get away from, this meritocracy, that supposed meritocracy that we have in this country. And, pull yourself up by the bootstraps and that kind of thinking. And I think that has a big part to do with it. Not doing away with the racial part, but just looking at another side of it too, is that there's a social component, and looking down on those of us who are not as fortunate as others. And that has a lot to do with this.
And on this, I think that's a great point and a great place to end. But I think there's convenience in that, because on this particular topic, they will all be on Medicare at 65, and they'll want it and they'll need it because they won't have an affordable option elsewhere.
Yeah.
And so when it's convenient for them, it's a great program. And when it's perceived as giving something to someone else, it's an entitlement program. It's a welfare program, and forget it. And it's a really misguided notion on this particular topic, because if you're paying taxes, you're paying into this program. And you're only eligible if you're paying taxes. So it's a hypocritical position as per the huge. But I think we should pick up there on the 8th, because I do think it's a great point. Thank you for bringing that up. Yeah,
absolutely. Thank you, guys. We'll see you in 2 weeks, 7 o'clock, Thursday, October 8th. Good night.
Bye, guys.
Stay safe.